Very respected faculty, seniors, and my dear colleagues. A very good morning to one and all. Today we will begin with we will begin with the discussion with a small clinical scenario. So we have a 24-year-old male patient who is a known case of chronic kidney disease on maintenance hemodialysis twice weekly. Now he actually has presented to the ED with the complaints of shortness of breath since last 2 days. This is the primary survey. Devashish. So how will you triage this patient? Anything else would you like to do before you shift the patient from the screening to the red area? Okay. On what oxygen you'll start with face mark or something else? Okay. We'll get to know. Okay. So, Abhiraj, so what would be the possible DDs in your mind when you get such a patient? Okay. Anything else? Okay, the possible DDs would be, as Abhiraj said, depending upon, based on the clinical scenario, the first thing that comes to our mind would be an acute decompensated heart failure, and it can be any other cause of cause of pulmonary edema, non-cardiogenic causes of pulmonary edema. And if the patient is a known case of bronchial asthma, it can be an exacerbation of bronchial asthma or COPD. It can even be a small LRTI or even a pulmonary embolus. So the topic for today's discussion is acute heart failure. Myself, Dr. Sanith KR, Junior Resident of Department of Emergency Medicine, and my moderator is Dr. Jamshed sir. Okay. So the objectives for today's discussion will be: first we'll be going through the epidemiology, then we'll be briefly discussing the pathophysiology, then we'll go ahead with the classification of acute heart failure, then we'll see how to diagnose this and the management and the disposition part from the ED. Okay. So in the epidemiology, the sad fact is that the epidemiology of heart failure as such in India is largely unexplored. Forget about acute heart failure, even the heart failure, the epidemiology part is not largely explored. So all we have is just pure hospital-based data or community-based registry. That is all we have. So there is a study by Chaturvedi et al., which is called as the Indus study, which was published in 2016. It estimates that around 1% of the total population of a country is having heart failure. That accounts around 8 to 10 million patients. And there is another finding from that, it is there is an alarming burden of heart failure in India, despite our population is much younger when compared to the developed nations. So we go on to define heart failure. Heart failure is the pathophysiological state in which the heart is incapable of pumping a sufficient supply of blood to meet the metabolic requirements of body, or it requires an elevated ventricular filling pressure to accomplish this goal. Okay, even if the heart is able to pump sufficient amount of blood, the second part is more important here. It requires an elevated ventricular filling pressure to accomplish this goal. Okay, and according to the 2022 AHA guidelines, heart failure is a complex clinical syndrome with symptoms and signs that results from any structural or functional impairment of ventricular filling or ejection of blood. Okay, so this is from AHA 2022. In that, heart failure is as such being is staged into stage A, B, C, and D. So in stage A, basically the patient is having only some risk factors for heart failure. It may be hypertension, it may be a coronary artery disease, it may be obesity, it may be any exposure to some cardiotoxic agents. In stage B, the thing is that the patient doesn't have signs or symptoms of heart failure, but there may be some structural heart disease or evidence of increased filling pressure associated with some risk factors. Okay, and it is in stage C and D that our main concern comes for the patient presents to ED. The stage C, the patient will be symptomatic with signs and symptoms of heart failure, whereas in stage D is considered as refractory heart failure, where the patient is not responding to the therapy. Okay, so coming to the topic in proper, the acute heart failure is a clinical syndrome of either new onset or worsening signs and symptoms of heart failure. So it can be either a new onset heart failure or worsening of the pre-existing symptoms of heart failure. So it basically
that registry said that the incidence or the prevalence of acute heart failure is much higher in African American people rather than the other people like the who avoid who are taking the military education. So African American or similarly the Asian or the Southeast Asian region, the heart failure is much more common and it involves the early age group.
So acute heart failure basically covers a wide spectrum of wide spectrum of severity. That is, it can vary from a simple gradual increase in leg swelling associated with shortness of breath on exertion and decreased tolerance to exertion, and which can go abrupt on, which can reach up to an abrupt onset pulmonary edema, which can present as severe respiratory distress. As I told, in acute heart failure can be a de novo heart failure or a new onset heart failure, and it can be a decompensation. It is so told that around 20% of the cases that present to the ED are de novo heart failure, whereas 80% are basically decompensation from the prior heart failure state. So in AHA, we explained this is a recent update. In that, the stage C, for the symptomatic heart failure part, they are telling that the trajectory of the stage C heart failure may be initially it can be either a de novo heart failure or a resolution. From that, there may be resolution of symptoms. It can be progress to stage B where it becomes the persistent heart failure, and it can be worsening of heart failure. So our concern that our topic as such will focus on these two things: the de novo heart failure and the worsening heart failure part. Okay, going back to the cardiac physiology, we know that the cardiac output is basically directly proportional to the stroke volume and the heart rate. The stroke volume as such is the amount of blood that is pumped by the ventricle during each cardiac systole. Okay, then so the stroke volume is basically dependent upon mainly three factors. It is the intrinsic contractility of the ventricle, depends upon the preload and also the afterload. Okay, I'm not going in detail regarding the how what happens with the contractility, what that the factors, what things happen. We'll just focus on some factors that can increase and decrease the contractility. Because we know that the catecholamines or cardiac glycosides can increase the contractility. Whereas the things that can decrease the contractility, which are more important in our today's discussion, would be there are some physiological factors like hypoxia, hypercarbia, ischemia, or acidosis can decrease the contractility. Whereas there are certain pharmacological agents, it might be calcium channel blockers, beta blockers, or antiarrhythmic drugs, or even alcohol can decrease the contractility. Now coming to preload. Preload is basically the amount of force stretching the myofibril or before the contraction. So it will be directly proportional to the end diastolic volume of the heart. So Gibran, can you please give me what is called as a Frank-Starling relationship or Frank-Starling law? Okay, exactly. So within physiological limits, the force of ventricular contraction is directly proportional to the end diastolic length of the myofibril. As the end diastolic length increases up to a physiological limit, the force of contraction increases. So we got to know that as the preload increases, as I told, as the preload increases, the force, the stroke volume is increasing. Okay, you can see that irrespective of the contractility, even if in case of a decreased contractility or there is an increased contractility, as the preload increases, the stroke volume is going up. Okay, then the second point is, as Jibran rightly pointed, after an optimal preload is reached, the further increase in preload doesn't increase the stroke volume, that it becomes a flat line. Okay, so as the venous return increases, the end diastolic volume increases and the force of contractility also increases. As such, it increases the stroke volume. Okay. The other thing about venous return is that it increases the pressure inside the ventricle also. Okay. So the pressure inside the ventricle basically depends upon the volume of the blood reaching the left ventricle or the compliance of the ventricle. Okay, it is not alone dependent upon the volume, but it also depends upon the compliance of the ventricle. So it is we can see that in the case of the if the ventricle, in the case of the normal ventricle, as the volume increases, there is not that steep rise in pressure in inside the left ventricular or left or the right ventricular cavity. Okay, so as you can see that there is a gradual rise in pressure inside the ventricular cavity. But as in the case of an acute MI or in if there is fibrosis in case of a chronic heart failure, we can see that the compliance of the ventricle comes down so that there is a steep rise in pressure. Okay? So what happens is that this rise in ventricular pressure predisposes the patient for developing pulmonary edema so that as the pressure inside the ventricle increases, it leaves back pressure which produces pulmonary edema. So this steep rise in pressure because of the non-compliance of the ventricles predisposes the patient for developing pulmonary edema. Okay. Then coming to afterload. Afterload is basically the pressure against which the heart must pump to eject the blood. Or it can be also told as it is a tension on the myocardial cells during contraction. And this afterload is determined by mainly two factors, that is the peripheral vascular resistance and the cardiac chamber size. Okay, the peripheral vascular resistance, we know it will be depending upon the viscosity of the blood and the cross sectional area of circulation. Okay, the cross sectional area of circulation, we know that the what colleagues, can you please give me what are called as resistance vessels in our circulation? Yes, the arterioles are called as the resistance vessels because they can change the caliber or contract and increase or decrease the peripheral vascular resistance according to the demands of the body. Okay, then as the viscosity increases, the peripheral vascular resistance again increases. Okay, so we know that when we have got a failing heart or the contractility of the heart comes down, the ventricles basically dilates in order to increase the end diastolic volume so as to increase the stroke volume, depending upon the based on the Frank-Starling law. The problem with increase in this ventricular cavity is that according to the Laplace law, the wall tension is directly proportional to the radius. So that the larger the ventricular cavity, the larger will be the tension over the myocardial wall, and larger will be the myocardial wall, and larger would be the afterload. Okay, so the heart will have to pump against a greater resistance as this afterload increases. So coming back, the cardiac output is again stroke volume directly proportional to stroke volume and heart rate. The relationship with heart rate is that the cardiac output is directly proportional to heart rate. That is, it increases with the heart rate up to a heart rate of 150 to 160 beats per minute. But after that, we can see that there is a decline in heart rate. It is basically because of the diastolic time decreases when the heart rate goes up. The other factor is that the perfusion to coronaries or the perfusion to the myocardium takes place during the diastolic time. So as the diastolic interval comes down, the perfusion to coronaries come down, hence the cardiac output comes down. Okay, so moving on to pathophysiology. The thing is that the physiology of cardiac failure should be considered as a dynamic one. The thing is that it continually adapts to optimize the organ function. Okay, when the cardiac output comes down, it tries to bring up the perfusion by various sympathetic activation of the sympathetic nervous system activation through the RAS pathway, renin-angiotensin aldosterone system, natriuretic peptides, endothelin, vasopressin, and other regulatory mechanisms. But the thing you got to know is that all these mechanisms that try to compensate for heart failure comes at a cost. It leads to some maladaptive structural and electrical events. So this maladaptive structural and electrical events, it again leads to what the fibrosis and apoptosis of the myocardial cells and leading to fibrosis and increase in extracellular matrix. Okay, and this further impairs the diastolic and the systolic function of the heart. So what happens? The loop again continues. The diastolic or systolic function again deteriorates. The heart again tries to compensate, but it comes at a cost, and this loop continues and continues. And it makes the heart failure worse. Okay.
So it's cardiac
Now coming to the classification of acute heart failure. This is based upon the European Society of Cardiology guidelines, which was published in 2005. It is basically it helps us to find the cause of the heart failure and to know the precipitants, whereas it guides us in initiating the initial therapy. Okay, but you got to know that it doesn't mean that when a patient presents with acute heart failure that he should fit into a single category mentioned in this. It may be overlapping. It will be overlapping. Okay, so with that insight, we'll go into the classification. There are 6 phenotypic types of heart failure. It is hypertensive heart failure, pulmonary edema, cardiogenic shock, acute and chronic heart failure, high output cardiac failure, and right heart failure. In hypertensive heart failure, we got to know that there will be signs and symptoms of heart failure, but the left ventricular ejection fraction will be preserved and the BP will be more than 140. The other thing to notice is that the symptom onset will be less than 48 hours or 2 days. So such patients are classified into hypertensive heart failure. The next is pulmonary edema. In pulmonary edema, there will be signs and symptoms of pulmonary edema. That is, the patient will be in respiratory distress. There will be bilateral crepitations and auscultation. The oxygen saturation may come down, and there will be findings on chest radiograph or bedside ultrasound. Okay. The cardiogenic shock is if there is evidence of tissue perfusion with a systolic BP of less than 90 millimeters of mercury. Coming on to the acute and chronic heart failure, the thing is that there will be signs and symptoms of heart failure, but that doesn't come up to the level of hypertensive heart failure or pulmonary edema or cardiogenic shock. And the systolic BP in this acute and chronic heart failure would come in between 90 to 140 millimeters of mercury. Okay, and it is typically associated with symptoms of peripheral edema, and the symptom onset will be gradual. That may be over several days. Now coming to the high output cardiac failure, it typically presents with tachycardia and warm extremities in contrast to others, and there may be pulmonary congestion also. And it is mainly it may be associated with anemia or thyrotoxicosis and all. The right heart failure, it is basically a low output syndrome. There may be back pressure from the right atria, right ventricle to the causing raised JVP, hepatomegaly, and pedal edema, and the patient may be hypertensive also. So, okay. So this is basically the classification of the European Society of Cardiology, which was published in 2005, which helps us to look at the cause and the precipitating factors, whereas helps us in initiating the therapy. Okay. Now, this is from AHA guidelines and 2020 guidelines. In that, the heart failure is based, it is not acute heart failure as such, but heart failure is classified according to the left ventricular ejection fraction into four types mainly. It is not just the ejection fraction, it also depends upon the ventricular intervention in left ventricular filling pressure. So the pressure inside the left ventricular cavity. Okay. So the first one would be heart failure with reduced ejection fraction. In that, the ejection fraction will be less than 40 percentage. Then we have a heart failure with mildly reduced ejection fraction or heart failure with, in that it would be the ejection fraction will come around 40 to 41 to 49 percentage with evidence of increased left ventricular filling pressure as seen by rise in the natriuretic peptide levels or invasive monitoring or through invasive monitoring. The last one would be heart failure with preserved ejection fraction. That is, ejection fraction will be more than 50 percentage, but the left ventricular filling pressure would be increased. In between, there is something called as heart failure with improved ejection fraction. So, if the patient presents with heart failure with moderately reduced or reduced ejection fraction, it can the patient on giving therapy, the patient can improve. Such patients are classified into heart failure with improved ejection fraction. Okay. Now, for the completion sake, we have another classification called as a Forrester classification. In that, we classify the heart failure into warm and dry, and there is like presence of pulmonary edema and shock. If the patient is having pulmonary edema, we classify them as wet type, and if there is no pulmonary edema, dry. Whereas the presence of shock or shock, they will be taken as cold and not shock warm. Okay. The thing that you got to know is that the type with warm and dry, that is Forestier class 1, is having the best prognosis, whereas the class with cold and wet, that is Forestier class 4, is having the worst prognosis. Now, moving on to diagnosis. So, there is, as such, there is not a single diagnostic test that can tell us that the patient is in heart failure or is having an acute decompensated heart failure. Okay, so the initial global judgment, that is depending upon the history, the physical examination, whatever edgings we have, the sensitivity is around 61 percentage and the specificity is around 86 percentage. So this guideline, so this is basically from the 2022 AHA guidelines, in which initial assessment will include not what we normally do. The clinical history will be there, the physical examination part, the possible edgings we can have. Okay, and it includes a measurement of natriuretic peptide levels. Okay, from there we'll go to get a transthoracic echocardiography, by which we can divide the heart failure into one with reduced ejection fraction, one with mildly reduced, or no preserved ejection fraction. Okay, this is the general outline for the diagnosis of acute acute decompensated heart failure or heart failure. Okay, so and then the history part. So in the history part, basically there are certain factors that predisposes, as we mentioned earlier, which were classified into the group of patients that were classified into stage A of heart failure. Okay, that may be hypertension, diabetes, valvular heart disease, old age, or male sex and obesity are the factors that can predispose the heart patient for having heart failure. Okay, and it is dyspnea on exertion. It is a symptom that has got the highest sensitivity, whereas PNT, orthopnea, or edema are considered to be the symptoms that have most specificity. In the symptoms, and they can be classified into basically that due to fluid accumulation or due to reduction in cardiac output. In fluid accumulation, the part it may be dyspnea on exertion may be there, orthopnea may be there may be edema, or as I said, there may be hepatic condition or hepatomegaly that causing pain and abdominal discomfort due to the distension from ascites. And due to the reduction in cardiac output, the patient may have early fatigue and generalized weakness. Now, in the history part, we should also focus on what may be the possible cause of heart failure also. As we all know, the most one thing to most common is ischemic heart disease or an acute myocardial infarction. The non-ischemic causes can be hypertension, it can be any cardiotoxic drugs, endocrine or metabolic causes, any arrhythmias can cause, myocarditis can cause, or even substance abuse can cause heart failure. So the history should focus on this part also. What are the factors that can either that can cause heart failure? The other thing to focus on would be the precipitants of heart failure. The common precipitant for heart failure is basically when a patient is a known case of heart failure who is on therapy is non-compliant to that. Okay, or if there is an excess salt or water consumption by the patient can again decompensate the patient. Then he may have renal failure. What we usually see if the patient is on maintenance hemodialysis, he skips hemodialysis, he is high likely to go for decompensation. Then, if there is the hypertension part is not poorly controlled, it increases the heart afterload and leads to decompensation. Then there are certain iatrogenic causes like if there are some negative inotropic agents that are used, if there is some agents like which causes salt retention, that is NSAIDs may be there, steroids may be there. Okay. Then if the therapy that advised is not inappropriate and if there is an addition of some new antiarrhythmic agent. So the history should also focus on these factors that can precipitate an acute heart failure. Now coming on to the physical examination. The thing is that the, the examination finding that has got the highest specificity is told to be the left ventricular S3 or extra heart sound. But the problem is that to detect an S3 in such a busy buzzing ED is too difficult, so the sensitivity of that is too low. Sensitivity is only 11 percentage, whereas the specificity comes around 99 percentage. The other factor that is hepatomegaly has also got similar higher specificity, whereas low sensitivity. And coming to bilateral crepitations of edema and JVP, they are the symptoms or signs that have got higher sensitivity, but higher sensitivity and comparable specificity also. Okay. Now going to the adjuncts. Vinayak sir, can you please interpret the ECG for me? It would be difficult. Anything else you want to add? Okay, so there is basically it is irregularly irregular and we can't find a discernible P wave in it. Okay, and it is said to be the QRS complex will be narrow unless there is a pre-existing bundle branch block. Okay, and how to calculate the heart rate in an irregular rhythm? Rahul, can you please help me with this? Okay, how is that? How much? Okay, exactly. Then, okay, can you help me in this ECG? If you can't see, you can come up. Yeah, it comes around 130, 140 beats per minute. Okay, so it is an ECG of atrial fibrillation with fast ventricular rate. So ECG is basically it helps us to identify the cause or precipitant and which causes for the acute decompensation of heart failure. So it can be an acute myocardial infarction that causes a which can cause a de novo heart failure or or a decompensation of acute heart failure, or it may be a rate-related heart failure, which is most common is atrial fibrillation with a fast ventricular rate. Okay. Now, the other thing is that other adjunct that can help in the diagnosis is that natriuretic peptides. B-type natriuretic peptide or NT-proBNP. It is usually recommended when the cause of dyspnea is unclear. Okay. The problem with the NT-proBNP or BNP is that it is affected by age, gender, and even body mass. Okay, and when we look at the causes of BNP, that The causes that increase the BNP levels. The other causes than heart failure is pulmonary hypertension. The common ones are pulmonary hypertension, pulmonary embolism, pneumonia, sepsis, or renal failure even can cause. But the list is too big. Okay, and the thing is that it has got age related variation also. So it is advised that the B-type natriuretic peptide or the NT-proBNP is best used when the diagnostic uncertainty exists, and it should be used in addition to the physician assessment rather than a routine measurement. Okay. Now moving on to the point of care ultrasound. Devan sir, can you please explain to me what this diagram is or what this flowchart is? Look protocol. What does it help for, sir? Okay.
Hello. Let's look at the lung sliding to see whether it's particular aspect. So on the left side, if we have free profile, the lung sliding will be profile is pulmonary edema. Then if it's a profile, it could be pulmonary embolism. So clear chest or dyspnea. So we look at the EVD. So then we find EVD basically a pulmonary embolism. If not, then we go for the plasma and we get the or otherwise then clear chest and short other side we have the absent lung sliding. So we then you can have basically the B dash profile is basically the profile without the like, so that is the ammonia. Other than that, then there could be A dash profile, like basically profile with non-static acid. So that is the most common. For non-common that is the pneumothorax without non-common that we have. But I will
Thank you, sir. So this is the thing that helps us more when we work in screening. We always get a patient with an undifferentiated dyspnea, and lung ultrasound always helps us out with this. Mostly helps us out with this. Okay. So specifically in acute heart failure, what are three things that we need to know from bedside ultrasound? The first thing is that are there any signs of pulmonary congestion? Next, we look at the IVC for its size and its collapsibility index. And then after that, we'll go for the left ventricular ejection fraction. Lastly, we got to know the left ventricular ejection fraction. So this is the algorithm based on these three questions. If there are more than two, or if there are in, we know there are 8 zones for lung ultrasound. If more than two, if if two or more than two of those zones are having more than three B lines, more than or equal to three B lines, that is B profile, or the B line count in all 8 zones is more than 10, we know that it is an indication, it indicates there is pulmonary congestion. Okay, so it indicates that acute heart failure is more likely. Okay, after that, we go for the IVC. If the IVC diameter is more than 2 centimeters or the collapsibility index is less than 50 percentage, we know that there is evidence of acute heart failure. And we get an, if it is not there, we'll go for BNP. Okay, still we'll get the BNP as an adjunct. So this indicates there is RV strain or evidence of heart failure. Okay, so after that we'll look at the ejection fraction. If the ejection fraction is more than 50 percentage, we'll take it like ejection fraction. It is heart failure with preserved ejection fraction, and if it is less than 50, we'll take it as heart failure with reduced ejection fraction. Okay. Now moving on to another adjunct, chest X-ray. Akhil sir, can you please read this chest X-ray for me? Okay. It's the cardiomechanics. So this chest X-ray basically is from a cardiogenic pulmonary edema. You can see the heart is enlarged, and there is central and pulmonary venous congestion. There is you can see also a small right side fluid effusion also. Okay. So the thing is that The sensitivity of lung ultrasound in detecting acute pulmonary edema is around 88% and it has got 90% specificity. When it comes to chest X-ray, the sensitivity comes down to 70% and it is similarly specific as lung ultrasound. Okay. Now, coming to the modified Framingham clinical criteria for diagnosis of heart failure. A major issue that was raised with this modified Framingham clinical criteria was that it mainly focuses on symptoms that related to pulmonary congestion. Okay, for in our case, we have patients usually with complaints of more patients complaining with symptoms of pulmonary congestion. So I think this helps us in diagnosis of heart failure in an ED setting also. Okay, it includes major and minor criteria. In the major criteria, we have PNT, orthopnea, elevated JVP, bilateral crepitations, the third heart sound. On chest X-ray, we'll have cardiomegaly or features of pulmonary edema, and there will be weight loss of more than 4.5 kg in 5 days in response to diuretics or response to treatment, presumed heart failure. In the minor criteria, we have bilateral pleural edema, nocturnal cough, dyspnea on exertion, hepatomegaly, pleural effusion, tachycardia, or weight loss more than 4.5 kg in 5 days. And to diagnose heart failure, according to this modified Framingham criteria, there should be at least two major criteria. It should fulfill at least two major criteria and or one major and two minor criteria, along with two minor criteria, which cannot be attributed to any other medical condition. Okay. Now moving on to the management of heart failure. In the management part, what I try to do is that we have initially we'll do a normal initial approach or a generalized approach. Then we will see what we usually do in hypertensive heart failure, what we do in normotensive heart failure, and cardiogenic shock. Okay. So the problem with this was that in the management part, when we refer to AHA or the European Society guidelines, they mainly focuses on the treatment of chronic heart failure as such, and the evidence or the literature on acute management of acute heart failure as such is less. So I have gone with the Tindanelli, the way in which the Tindanelli has been given, and I added whatever I can from this literature available. Okay. So the general approach would be first, as in any case, the airway assessment, and then we in the clinical scenario, we had a patient with a saturation, room air saturation of 85% and respiratory rate of 36 with increased work of breathing and bilateral crepitations. So we'll have to supplement it with supplement oxygen and if provide ventilatory support if needed. Okay, then vital signs should be assessed. The patient should be, if possible, the patient should be seated upright. Okay, then quick intravenous access should be obtained. Continuous cardiac monitoring should be kept because we know one of the causes for this precipitation or decompensation may be arrhythmias. Then we should go for early vasodilator or diuretic therapy and we should monitor urine output. Why? We'll come to it. Okay. So in the airway and breathing part, I told you when there is hypoxemia, that is the saturation is less than 90%, we should supplement the patient with O2. Ideally, we would start with NRBM with full flow. Okay, if NRBM with full flow, the only objection would be if the patient is also having COPD, they may not require this aggressive correction of this hypoxemia. Mehul, what would be the ideal target saturation for in such patients who have COPD? Okay, it is exactly. It is 88 to 92. So we will try to aim for this upper limit. That is 92% saturation is good enough in such patients who are having COPD with acute heart failure. Okay. Then, if even after providing NRBM with full flow, if the respiratory distress is not coming down and the patient is having respiratory acidosis and the hypoxia persists, we can give the patient a trial of NIV unless if there is no emergent indication of endotracheal intubation. That is if there is no cardiac or respiratory arrest, no severe respiratory distress, unstable, or if there are no unstable cardiac arrhythmias, or there are no contraindications to NIV. Okay, then we can give the patient a trial of NIV. Okay, what are the contraindications of NIV as such? The absolute contraindication, as I told, would be if there is a need for emergent intubation. That is, the patient is having cardiac or respiratory arrest, or there is severe respiratory distress, or if there is some unstable cardiac arrhythmias. The relative uh, contraindications would be there is other organ failure associated with this. There is encephalopathy, there is GCS less than 10, there is massive, there is upper GI bleed which is threatening the airway, facial trauma. If the patient is having higher risk of aspiration, that is not cooperating, is not able to protect his airway, or if there is chances of prolonged duration of mechanical ventilation, we don't ideally choose NIV. And what does NIV do? We all know NIV or it basically provides a positive pressure ventilation. So it helps in bringing down. The first thing what it does is that it brings down the work of breathing. Once the work of breathing comes down, the overall adrenergic flow that was trying to compensate for this acute distress comes down. The second thing is that the NIV provides, it opens the alveoli that were collapsed so that the functional residual capacity of the lung volume improves. Once the lung volume improves, what happens? The ventilation perfusion mismatches it gets corrected. Okay, it happens once this also moves on, adds on to what it also adds on once the improvement and ventilation perfusion mismatch adds on to the decreasing the adrenergic flow. Okay, once the adrenergic flow comes down, what happens? The heart rate and BP comes down. We all know this relieves the increased demand of the myocardium and it relieves the ischemia. The other part is that this positive pressure ventilation decreases the afterload and it improves the cardiac output and the systemic oxygen delivery. Okay, so this is the effect of NIV in patient who presents with acute heart failure. Now, we move on to hypertensive acute heart failure as such. In hypertensive heart failure, we know that the patient is basically afterload sensitive. So, the decrease in afterload by using vasodilator will benefit the patient. The role of vasodilators is that it decreases the arterial resistance, thereby it decreases the afterload. Okay, so that it will decrease the tension on the left ventricular wall, where thereby it improves the cardiac output. The other thing is that the vasodilation also decreases the preload. Okay, so that it again decreases the left ventricular filling pressure. Okay, so that the myocardial oxygen demand comes down and the overall contractility improves. Okay, this is the way in which the vasodilators act so as to improve the cardiac output or relieve the patient from this acute decompensation. Now, moving on, the vasodilator of choice, first choice is nitroglycerin. Nitroglycerin as such is a venous or venous and arterial vasodilator. It has got a rapid onset which occurs in around 2 to 5 minutes and it is very short acting also. Duration of action is around 10 maximum around 10 minutes only. The additional benefit is that it has got also coronary vasodilation properties. The dose start with MPG is 0.5 to 7 micrograms per kg per minute and it can go up to 200 microgram per minute. Okay, there is another subset, we'll come to that. The other option available other than IV formulation is that we can use 400 microgram sublingual by spraying of tablets every 5 minutes until there is relief of symptoms or the IV formulation is available. 400 micrograms every. Now, the adverse effect related with this would be hypotension may be there may be headache. We often see patients complaining of headache when we keep them on NPG. Tachycardia may be there. And if there is prolonged use more than 24 hours, there is a possible risk of methemoglobinemia. The second option would be nitroprusside, especially when we require further reduction in afterload. It is actually a potent arterial vasodilator and the dose to start with would be 0.3 micrograms per kg per minute per kg per minute. The adverse effects would be same. Hypertension would be there, and with nitroprusside, there is a chance of cardiac cyanide toxicity. But that comes only when we give high doses or prolonged use, or if there is an underlying hepatic or renal impairment. Now, loop diuretics. Loop diuretics are added in hypertensive heart failure when there are continuing symptoms even after relief of this blood pressure or control, even after controlling the blood pressure. Okay, and there was a study in by Carter et al., which was published in 1998, which tells that loop diuretics administered alone without vasodilators for hypertensive heart failure increases the mortality and may even worsen the renal function. We'll come to loop diuretics in proper and normotensive heart failure. Okay, so there are certain contraindications to vasodilatation. So if there are signs of already hyperperfusion and hypotension, we can't go ahead with vasodilation. And there are certain preload dependent states, which are there may be an right ventricular infarction, aortic stenosis, if there is hypertrophic obstructive cardiomyopathy, or if there is severe volume depletion, we can't go ahead with vasodilation initially. Okay, in that cases, the aim of therapy would be decreasing the outflow gradient by slowing down the heart rate and cardiac contractility. This can be done with beta blockers also. Okay, now I can't complete the hypertensive heart failure part without reviewing this article, which was published from our department, which is on. This was a review article on sympathetic crashing acute pulmonary edema. Okay, we all know we diagnose an sympathetic crashing acute pulmonary edema when there is an acute onset dyspnea, which is developing in less than 6 hours, when the systolic BP is more than 160/100 and the saturation is less than 90 and the respiratory rate is more than 30 with bilateral crepitations, and the patient will be diaphoretic and will be agitated. Okay, so the management is usually we'll go ahead with an NTG and NIV simultaneously. And NTG bolus will be given depending upon the BP, and we'll start him on non-invasive ventilation. Okay, and depending upon the response and the initial BP, the dosage of NTG comes. The thing is that if there is no adequate response, we can gradually up-titrate both NTG and NI. Okay. Now moving on to the normotensive heart failure. The mainstay of treatment in normotensive heart failure is loop diuretics. Okay, what they do is that they promote sodium and water excretion, and it decreases the intravascular volume, decreases the preload, and it provides basically symptomatic relief. The dose would be if the furosemide is most commonly used loop diuretic. The dose would be if the patient is not on any loop diuretics, we'll start with 20 to 40 milligrams IV. If the patient is on any loop diuretics, we'll start with a dose of 1 to 2.5 times the patient's previous total daily dose. Okay, and this comes from a study called as dose trial. Okay, this was basically a double-blind, randomized controlled trial which was in which furosemide was administered IV in two sets of patients. In first, they were given at a low dose, that is a dose equivalent to their prior regular dose, oral dose. The second part, they were given high dose, that is around 2.5 times their prior daily dose. Okay, so and this study gave us a reasonable starting point for IV diuretics, starting IV diuretics. So they recommended that 1 to 2.5 times the patient's previous total daily dose may be given to as the initial dose. Okay. Then the thing is that there was another study with time to furosemide treatment associated with mortality. It was another multicenter prospective study. In that, patients were treated with acute decompensated heart failure were treated with IV furosemide within 24 hours. And they noted that the early treatment, that is within 60 minutes, the patients who have received early treatment, that is within 60 minutes, were having a lower hospital mortality than later treatment. That would be 2.3 to 6 percentage. Okay. As and another observation was that as the time to dialysis is delayed, the risk of mortality is steepening up to around 100 minutes after that it flattens. Okay, these were the most important, the two important observations from this study.
Okay, okay, 6 minus 2.5.
Then, how to guide this diuretic therapy? Hmm? This was another article which helps us to guide this diuretic therapy depending upon the urine output and the urinary sodium excretion. Okay, what we can do in our EDs would be we will do it based upon the urine output. It is said that we'll possibly get an catheterize the patient and we'll look for this urine output after giving the initial bottles. We'll first test the patient at 2 hours. If the urine output is more than 150 ml per hour, we tell that there is adequate diuresis and we can continue with the same dose of loop diuretics that we were given. Hmm? Other thing is that if the urine output is less than 150 ml per hour, we can repeat a dose of double the initial starting dose. We do not wait for another 6 hours. We can give it around six in the second hour. We look at the second hour. If the urine output is not adequate, we can repeat the dose. Okay. So based upon this urine output, we can titrate the therapy of loop diuretics. Now,
The concept is measure the sodium at 2 hours after starting with the treatment. And ideally, then wait up to 6 hours, maximum 6 hours, just to see the increase in the. So at 2 hours, maybe it's not adequate enough. But if at 6 hours, it is not like 100 increase in
go to 6 hours. There is no symptom relief. Also, can we wait for 6 hours? It's confused.
I'm talking about the guidelines, the society of guides that better measurement was and wait up to 6 hours. But if a patient is symptomatic, it's not there, please the but guidelines says that wait up to 6 hours.
And the side effects of loop diuretics, there may be hypovolemia and hypotension, hypokalemia, hypomagnesemia, hyperuricemia, there may be perineal azotemia, and orthodoxy, especially when used with aminoglycoside antibiotics. So we have to monitor the patient for the same also. Okay. Now,
The question for the final year student, would you say that one thing that is active to the
Maximum tolerated dose and also like that. Like 300 like 400.
that is also true for ascitic therapy.
now moving on to the
Like, the question to the printer. Wrong. Finally, what they answered was Devashisha. Huh? Okay, half of conversation they're not listening. Understand? So it will speak in mic or something. Half of the conversation not being heard by the class benchers. Isn't it? So it is unfair. इसीलिए माइक में बोलो and direct your thing to call the whole class rather than speaking to the first 50%. Yeah.
Now coming to cardiogenic shock. The initial management will stay the same. We'll try with, if the patient comes in with hypoxia features and with hypoxemia, we'll go with oxygen. Then if it's not maintaining, we'll go with positive pressure ventilation. The thing to keep in mind is that once we keep the patient on positive pressure ventilation, we should be prepared because providing the positive pressure ventilation can further deteriorate the hypotension part. So we should be ready to administer IV fluids if a short bolus of 250 or 500 ml, if there are no evidence of pulmonary edema or any presence of, and it can even in the presence of RV, right ventricular infarction also. And if it is not responding to that, we should be ready to give inotropic support to the patient. And we should try to keep the positive end expiratory pressure to a minimum of possible. Now, how to manage the hypotension as such? As I told, if possible, we can give IV boluses of 250 to 500 ml initially. Then repeat after this initial 250 bolus, we have to reassess, and if we can give further, we can give. If there is no improvement with this initial IV bolus, or if there are features, signs, or symptoms of pulmonary congestion, we should go for inotropic support. That is, to treat the hypotension part, we have to go with vasopressors, and to improve the cardiac output, we have to go with the inotropes. So we have to understand that this support is basically just a temporizing measure until the definitive treatment comes in. So if it is an acute myocardial infarction who requires an emergent revascularization, this just provides a bridging time up to this intervention. Okay, so the agent choice will be dobutamine because it is used in the absence of profound hypotension. That is, it is more effective when the systolic BP is more than 90 millimeters of mercury. The thing is that even though it increases the cardiac contractility, it has a potential vasodilator. So it is recommended that we should add a vasoconstrictor along with dobutamine. Starting dose of dobutamine will be 2 to 5 micrograms per kg per minute, and it can go up to 20 micrograms per minute, kg per minute. So the vasopressors that can be vasoconstrictor agent that can be added with dobutamine would be dopamine and norepinephrine. The dopamine, the thing is that it is having inotropic effect with vasoconstrictor effect. Okay, but the problem with dopamine is that because of this beta agonistic activity of dopamine, it increases the heart rate and it increases the cardiac workload, which can further deteriorate the cardiac contraction. And it grows, and there is an increased risk of dysrhythmias associated with dopamine also. Okay, and so the recommended dose is 3 to 5 micrograms per kg per minute and can go up to 20 to 50 micrograms per kg per minute. The other option is norepinephrine. Norepinephrine, we know it is a potential vasoconstrictor and an inotrope also. Okay, so norepinephrine, and when it is combined with dopamine, has got more profound effect on peripheral vasoconstriction than when dopamine is used alone or dopamine is used along with dobutamine. Dobutamine is used alone or when it is used along with dopamine. Okay. So it is also the preferred single agent when the systolic BP is less than 70 millimeters of mercury. And the dose which we start with is 2 micrograms per minute, and we can up titrate according to the response. Then the other option is that inotrope, which is milrinone, which is an inotrope and a vasodilator also. It is basically when patients are on beta blockers, they may have an attenuated response to dobutamine, which makes which is just technically makes milrinone a better choice. So milrinone can be substituted for dopamine if the dobutamine is ineffective. But there was a trial called Doremi trial, which was a head-to-head comparison between this dobutamine and milrinone, and it showed no significant difference between these two. Now, what else we can? So we are done with hypertensive heart failure, normotensive, and cardiogenic shock.
There are cost-effective methods.
This milrinone is much more costly than dobutamine. So it is, as of now, it is recommended that we'll stick on to dobutamine as well. Then the other thing we should take care of that this heart failure predisposes the patient for increased risk of venous thromboembolism. So in hospitalized patients with heart failure, venous thromboembolism, in order to prevent venous thromboembolism, this anticoagulation is advised. Okay, it is said that there is risk up to 2 years since this heart failure, but the risk is much higher during the initial 30 days. Okay, but even though there are benefits of giving uh, anticoagulants post discharge also, the issue is that it has shown that there are more chances of bleeding manifestations. So as of now, it is recommended that we give anticoagulation when the patient is admitted. And the choice would be if the creatinine clearance is more than 30 ml per minute, we can give enoxaparin, which is at a dose subcutaneously once daily, or unfractionated heparin may be used, that is 5,000 international units subcutaneously every 8 or 12 hours. The other option is rivaroxaban 10 mg 40. Okay.
We are not following. We should follow it. We should start following.
They do not offer any between.
Now coming on to the disposition part. Disposition decisions are basically based on the physician judgment. That is our judgment based on the patient's clinical condition. The physiological risk evaluation. We should see the vitals, again re-examine the patient. Then the other factors such as the caregiver support, whether he can be compliant to the medications, whether he can follow up, all these comes into play and taking a disposition decision. Okay, and we have to admit the patients with certain high risk features. Okay, and I'll come to that. And those patients who require some intervention as such should be ideally admitted to the intensive care unit, and others can be kept in the non-ICU setup also. And there is another concept like we can keep the patient for 10, 12 to 20, 10 to 12 hours in an observation unit so that we can gradually we can observe the patient for his vitals and the symptoms and gradually discharge the patient. I think our setup, our ED works like that only. Once a patient with decompensated heart failure comes, we try to decongest and we discharge.
Right? Save the discharging the patient who was on just switch out one diuretic therapy, but we start with patient with weakness of the family. So we are not following the guideline, and we cannot follow the guideline. Guideline is to guide. If you are guiding, following the guideline in our emergency department, we will be inundated with this type of patient.
your senior Rajesh Shah. Because we just बंद हो गया ठीक हो गया बंद हो गया बंद हो गया तो निकल जाएगा stabilize हो गया continue.
So these are the high risk factors that indicates that the patient should ideally be admitted. If there is a positive troponin value, if the blood urea nitrogen is more than 40, creatinine more than 3, there is sodium less than hypernatremia, sodium less than 135, new ischemic changes, or a new onset acute heart failure. There is IV vasoactive infusions that were given, significant comorbidities associated with. There are respiratory rate is more than 32 breaths and is still requiring non-invasive ventilation at the time of consideration of this observation unit. We are trying to then if there are signs of poor perfusion. The social factors would be if there is poor social support or poor to follow up, they should be ideally should be admitted. He said that the study suggests that around 75% of patients who present with ADHF responds to therapy and will have no identifiable high-risk features and they can be discharged to home. And their rates of readmission are similar or better to the admitted group. Thank you.
Any question on heart rate? No. There are multiple trial and GC trial, ISIS 4 trial. They say that it is more symptomatic improvement rather than the mortality rate. You have to give both. If the patient is hypertensive heart failure or acute pulmonary edema, you have to give both. So it is not a problem. The mortality benefit is not there, but symptomatically a patient will be much faster when you give type of injection. Overall mortality benefit.
Second, again, first of all, your presentation was good. Okay, but with time. I think 1 hour was I think you that one of time. But you are in time. So I think the previous speaker was slightly greater time. But your presentation was really good. Only thing is, my feedback is the way you explained his slide was very nice. You had really highlighted point which is very important. Okay, that is a good sign of a good presenter. Your voice quality is really good. So actually, I'm hearing when you're starting now, where I had got some periodic meeting. Speaking, as the classes started, because your voice was, banging to the next door. Where you were, voice. So it is such a powerful voice you have, like a triple R voice, right? So that is number one, right? You don't have tics. Voice tick, R, E, O, so exactly, these are the repetitive words, which you don't have. So that is also a sign of a good quality, right? What do you need to do? You need to do a voice modulation. So maybe for the batches, the new this thing, we can have a session of micro teaching for all of you, so that you understand the tricks and trade and techniques of presentation. Formal training we will like to give, because that will organize for it all. So I am telling you the basic ingredient which you have. So second thing is slide wise, I found that slides can be improved. So a lot of slides just crowded. Even though in crowded slides you try to balance it a negative criticism by highlighting the points in red. You go back to one of your slides, first have seen it is in paragraph form. Isn't it, Sanith? Paragraph form. So it should be bulleted points, right? But you try to balance it by highlighting the points in red, which is important. The rest, because nobody is interested to read the whole thing. So nobody is interested, and it looks bad. Now it's like, but only you need to improve that voice modulation, and you should have a you should have a summary slide. Understood? Like you have the objective slide, what you are should have a 35 state, dialogue, and closure. The three parts of the objective, dialogue, and closure in summary. Okay, so you should have a summary slide also. I think this is for Sridevi as well. Okay, Sridevi also should have that, and you should have an opening slide. Scenario is fine. You've learned the technique, start with the scenario, right? And then you came to the topic. Okay, that is how you divide it. Otherwise, it was a very nice presentation. Big round of applause for Sanith.